I have nothing to disclose. As we know, both anticholinergics and alpha blockers are widely used to treat BPH. Two early meta-analyses showed combination therapy may have a better effect compared to alpha blockers. However, two later trials showed no significant difference between combination therapy and alpha blockers. So our study aimed to evaluate the effect and safety of combination therapy. When we talk about meta-analysis, maybe we have to think about PICO's principle. We focus on the participants men with the BPH more than 40 years old, with the IPSS more than 8. We focus on the intervention in the combination therapy. We perform 3 different comparisons: combination therapy versus alpha blockers, placebo, and anticholinergics, respectively. The primary outcome include IPSS, quality of life, and adverse events. The secondary outcomes include AUR and surgical intervention. Only RCTs are studies we are really interested in. We performed the update search just 1 week ago. Totally, we searched 10 different databases. Results. And if we focus on the IPSS, we can find combination therapy may result in a significant improvement in IPSS compared to alpha blockers. However, this difference didn't meet the minimal clinical importance. Similarly, combination therapy may result in improvement in quality of life, but still not meet the clinical importance. Combination therapy may increase adverse events. That means in every 1,000 patients, the combination therapy may cause 71 more adverse events. Combination therapy may have no significant difference in AUR and surgical intervention compared to alpha blockers. In terms another comparison between combination therapy and placebo, we can see combination therapy may result in improvement in IPSS, but still don't meet the clinical importance. Combination therapy don't have a significant improvement in quality of life. Combination therapy still increase adverse events, but not in AUR. Another comparison between combination therapy and anticholinergics, we can see combination therapy don't have an actual effect in IPSS compared to anticholinergics. But for quality of life, combination therapy may result in improvement. Combination therapy may result in no significant difference in adverse events and AUR. So, conclusion. Combination therapy has a similar and small important effect on IPSS quality of life compared to alpha blockers, placebo, and anticholinergics. Combination therapy may increase adverse events, but not increase the AUR and surgical intervention. Thank you for your attention.
So this makes rather depressing reading.
Sorry?
So this makes us feel very bad, your presentation, because these combinations, when looked at in the meta-analysis, have very little advantage over single treatment.
Yeah, right.
So it's depressing. It makes us feel...
Mr. Chairman, I do not share your depression. Indicating that there are some side effects, but no major or clinically very relevant side effects in terms of retention in this series. So I think that's an important conclusion. So adding up, anticholinergics does not create retention, which was the big fear. So this meta-analysis confirms that. In terms of efficacy, what this analysis shows is that for a group of patients, there is no significant additional effect. But we know that these therapies only have an efficacy in 40% of patients that will not work in 60% of the patients. So when you include this 60%, indeed you come to this conclusion. But for the 40%, there is an additional benefit, which is not shown in this trial because it's looking at 100% of the patients. So in an individual decision of a patient with severe lower urinary tract symptoms from the storage part, there can be an additional benefit, and this analysis indicates that doing that does not increase the risk of urinary retention. So that's a very positive message, I think, and I do not share your depression. I hope I got you out of that.
No, you haven't got me out of it, no. And I think one of the problems with these trials is that the patients are very poorly categorized. So you use the term, I shouldn't have complimented you at the beginning for using BPO because you then use BPH. BPH is histology. We're not treating histology. But the main problem with these trials is you don't actually know who you're treating because the assessment of the patients is very poor. The IPSS is used, so you don't pick up urgency incontinence as a sign that they may have overactive bladder. The assessment of prostatic obstruction at best is from flow rates and maybe post-void residual, so the patients may have detrusor underactivity, which is utterly indistinguishable from obstruction on the basis of symptoms. So, of course, we can't expect very good results because it's a heterogeneous group of patients, many of whom don't need the treatment that they receive. None of them have probably had proper conservative management before they go into the drug trials. So I think yours is an excellent meta-analysis, and it shows the true state of our knowledge, which is not very good. So I would argue that male LUTS is still being treated very badly. Lots of patients are having their time wasted because they're not looked at properly. The use of the term BPH is completely wrong. It gets the wrong mindset. All it means is the patient has a prostate. And that's not what we're interested in. We're interested in whether they're obstructed. And we shouldn't be giving drugs for obstruction unless we've got very good evidence. Because although there aren't any serious side effects, we all know that even alpha blockers, which are pretty safe, make some people feel tired and, a bit miserable. Anticholinergics, of course, make a lot of people feel uncomfortable and relatively unhappy. So no drugs have no side effects. They may not kill them, and we've known for a long time.
Again, I'm afraid I have to disagree with some of your statements. I agree with the BPH versus benign prostatic obstruction. Of course, we agree. Definitely, we are in the ICS, so we should agree upon that point. But I disagree with the fact that you say that they're poorly conducted studies. As you've seen, I'm author of at least 2 of the studies that have been mentioned in the meta-analysis, so I take it personally.
But you didn't declare your conflict of interest just then. Dr. Rossier, he's gone.
Yeah. No, I do not agree because I think with such a large meta-analysis in the studies, it's quite representative of the group of patients that are seen by clinicians. And these patients have clinical problems. And I agree that if you want to have a correct diagnosis, indeed, urodynamics would be essential to show what is the degree of obstruction or the degree of underactivity and so on. In routine clinical practice, this is not possible. And therefore, these trials are mimicking the situation in which a clinician has to take a decision for an individual patient. And there are clinical parameters that allow to have a trial and error approach. And then when we know that there are no major side effects, I think it is acceptable to propose a treatment and make a subjective evaluation and see what it does for the patient in terms of subjective and some objective aspects of their pathophysiology.
Have I got time for a rebuttal?
Yes, you have.
Okay. So, of course, Professor Van Karrebroek is quite correct in saying we can't do pressure flow studies on everybody who comes with LUTS. But on the other hand, you can take a proper history. You can use a proper questionnaire that asks about overactive bladder symptoms. You can do proper flow rates. If you look at flow rates done in the community, they're done very badly. If you do proper flow rates, then they have a much better predictive value for obstruction. So you can be more confident that your patient actually has prostatic obstruction. If you do a single flow rate in a busy outpatient, it's very poor. We've shown years ago doing a second flow rate gives you much better results. So we can use simple testing to get a much more accurate diagnosis than we do at the moment.
I'm very happy that we could conclude with a consensus. Thank you very much. Thanks to the speaker. We move on to the last